She is a philosopher who teaches bioethics and professionalism for medical students and residents, as well as master's students. She also serves as a clinical ethics consultant for Houston Methodist Hospital. Some recent projects focus on ethical issues in fetal therapy, utility of genetic testing in the context of childhood cancer, the impact of disclosing information about dementia risk, and medical decision-making at the end of life. Please welcome Dr. Janet Malek.
All right, thank you for the invitation to be here. Today I want to fill you in on what is one of the most controversial hot topics in clinical ethics, and it's also probably something that I'm going to guess most of you have never heard of. It is a procedure that is used to procure organs that will be used for transplantation. It's called normothermic regional perfusion, or NRP. Sorry, I'll stand back here so you guys can see. NRP consists of a process that when it's been decided that a patient is going to have their life support withdrawn due to the decision either of the patient themselves, more commonly the family. They say, you know, for whatever reason, due to their underlying medical condition, often involving neurologic issues of some sort, brain injury or other types of chronic diseases, that they are going to withdraw life support from a patient, generally who's on a ventilator, but they want to donate their organs for transplantation for others. So this process involves taking the patient into an operating room, removing them from the ventilator so that their heart, lung function stop. There is a 2 to 5 minute waiting period that is meant to determine for sure that the patient is no longer able to breathe or their heart is functioning on their own. At that point, they take cannulas and insert them into the patient's veins and arteries, and they clamp the veins or the arteries that supply blood to the patient's brain. At that point, once they're certain that there cannot be brain perfusion reestablished because of these clamps, they put the patient on a heart-lung machine and restart their heart and circulate blood through their body so that the organs can be preserved in better condition for transplantation. This is called NRP, normothermic regional perfusion. Some of you are nodding. I think maybe you've heard of it, but others look a little bit afraid of this procedure, understandably so. So in order to really understand how we got to this point that we're considering NRP for normal practice, we need to understand a bit about the history behind it. So in the 1950s, we saw great advances in life-sustaining technologies. We saw the mass production of a ventilator that is going to allow us to keep patients alive, even when in other situations previous to that time, they would not have been able to survive. This also caused some ethical questions, though, when we started to see patients that were able to maintain their cardiopulmonary function due to the ventilator support, but they never woke up. And people started saying, what should we do with these patients? At the same time, in the next decade, we saw huge advances in organ transplantation. During the 60s was when we saw the very first kidney, liver, lung, heart transplants. They weren't super successful, but they did offer hope for future patients. So with these two things coming together, we're seeing a need for more organs, and we're having these patients who are in these, what are they called, a hopeless coma. And then there's these dilemmas that started to raise with what should we do with these patients? And maybe we could use their organs to help save other people's lives. So in 1968, they convened a committee, which of course is what you do when you have interesting ethical questions, at Harvard, and they were supposed to determine the definition of what they called brain death, which was going to be an approach that they could use to ensure that we were all clear and on the same page about when and how one could declare brain death about a patient and then use those organs to be transplanted for somebody else. So they were very explicit that they wanted to address the problems of the hopelessly unconscious patient, as well as prevent controversies about organ transplantations. The result of the committee was not a definition of death. It was a definition of what they called irreversible coma, which really didn't solve the problem at all. However, it did conclude that a patient who is in an irreversible coma is, for all intents and purposes, dead, and so that their organs can be transplanted. So they essentially just sidestepped the real philosophical question about what is death and when is a person really dead. They just said we can choose to use their organs under these certain circumstances. Okay, right, yeah, I know. So ongoing debate. In the 1970s, this was not resolved. The questions continued. They convened another commission. Excellent, another good idea. At this time, it was a president's commission, and they came to the conclusion that they actually offered a substantive philosophical assessment, which is that once a patient, once their brain is not functioning in a way that it can integrate the body's different functions or organizations, it doesn't count as an organism anymore. And so without adequate brain function, we can declare a patient to be dead. And this was actually instantiated into what we call the Uniform Determination of Death Act. So when you have a tough philosophical question, might as well just pass a law and try to solve that problem. So that's what they did. And they declared that an individual who sustained either irreversible cessation of circulatory and respiratory functions or irreversible cessation of all functions of the entire brain, including the brainstem, is dead. And this actually solved quite a few problems. It was adopted by just about every state in the United States, and it provided this opportunity for kind of a tenuous consensus through the 1980s. We sort of developed this mantra that brain death is death. We don't call it heart death, we don't call it lung death, so we shouldn't call it brain death. Death is just death. In response to some of these sort of concerns, we said, well, we're not going to call it brain death anymore because that kind of qualifies it. We're going to call it death by neurological criteria. And under this sort of approach, we were able to achieve organ transplantation for many people. The organs were good quality because they were taken after the person had still had a good circulation in their body. There were still a few, and the ethicists, not the legal folks, but the ethics folks came up with what they call the dead donor rule, which is saying we should only harvest organs from, you're not supposed to say harvest, procure organs from a patient when they have been declared dead. So this was a fairly happy place that everybody was at. There were still a couple of questions about whether we should be considering only higher brain criteria so that you didn't have to have the whole brain not be functioning, but that was largely rejected. Some raised concerns about residual functioning of the brain because there's still hormonal function, electrical activity that goes on, but again, those were sort of put aside. And so we had this fairly good set of agreement until we get to 2013. In 2013, we had the Jahai McMath case, which is something that some of you might be aware of. Jahai was a 13-year-old girl who went into a hospital in California for a tonsillectomy. Unfortunately, she had several complications that involved bleeding, a loss of blood to her brain, and she had a cardiac arrest. They did CPR and resuscitated her, but by the time they got her heart started again, she had had irreparable brain damage. The doctors in California declared her dead by neurologic criteria. Her mother did not accept that diagnosis and was able to get her flown across the state, across the country, to New Jersey, which is the only state that allows this exception, where if someone objects to the declaration of brain death by neurologic criteria, they're allowed to keep her alive. She lived for another 5 years. It was discovered later that there was some brain activity. It was minor, but it raised questions about the original diagnosis. So as you might imagine, this case threw the whole medical community into disarray about the definition of death, right? If we can't reliably declare death, how can we say somebody has died by these criteria? So this controversy has continued. In 2020, they convened an entire summit of people internationally to try to figure this out, and they were still unable to come to what they considered to be an appropriate definition of death. So that's where we are. When we're thinking about NRP is ethically dependent on this idea of death by neurologic criteria because it is only effective because we're restarting a person's heart and lungs. We are assuming that the only way that we can ethically do that is if they are brain dead. But of course, NRP is caught up in this whole question of what is brain death and whether it's acceptable. There's also a lot of debate about the fact that there can be a lot of good done by using NRP. It's consistent with the reasons and the sort of intentions that patients have when they agree to give their organs. They want their organs to be given to somebody else for something good to be done with the fact that they have died. And we also see that this process has increased organ availability and quality. On the other hand, it might be violating what we call this dead donor rule, which has been put in place by ethicists in order to say that we would never take organs from somebody who isn't actually dead because we want people to trust that we're not going to compromise their medical care based on the fact that we want to procure their organs. So this is an ongoing controversy. I wish I could say I had a particular answer for you on it. I don't, but it's something that you should be aware of. Thank you.
Thank you. Thank you so much. We have an audience question. I think we got time for one audience question. Over here. Sarah Beth's coming to you.
Hi, Roman. I'm interested, what is the percentage of people actually get their organs procured that way?
Right now, it's quite a small number because only a few hospitals in the US are doing this. More and more larger hospital systems are considering doing some version of this procedure anyway. It has been done in Europe for a long time, though, for several decades.
Dr. Janet Malek, thank you so much.